Okay, as you guys are getting settled, before I introduce Jane Coyne, I want to give some context to this. So, as we talked about earlier, there are actually a lot of us in the audience who, although we don't do engineering on a day-to-day basis, we were trained as engineers. And whoop, whoop. Hands up if you were trained as an engineer. There we go. See? Yeah. And one of the things that they teach you in engineering school is there are some problems that are only solvable if you actually assume the boundary conditions. And once you assume the boundary conditions, you can use different techniques to solve those problems. And most of engineering works that way. Don't be frightened by that. It's worked for a long time. However, when you really want to challenge system performance, what you do is you assume extreme boundary conditions. And in fact, when I worked in the aerospace industry, I worked on the F-22 Raptor program, and one of my jobs was to assume the most extreme flight conditions possible and to predict numerically whether the turbine blades of the engine would melt. Now, imagine telling the Joint Chiefs in a meeting along with their staffs that their baby is going to fly really great, but the turbine blades are going to melt and it's going to blow up the engine. That's really a bad conversation, which I, by the way, had to have at the age of 23 in front of a lot of military people. It taught me a lot about delivering bad news. My point of that is, when you assume extreme boundary conditions, you learn something profoundly different about the products that are being used in those scenarios. And when we were thinking about the way to sort of close out the content portion of the day before we go to the wine reception and dinner, we sort of wanted to look at some extreme boundary conditions as we think about the global delivery of healthcare and the use of medtech products in those contexts. And I was assigned / volunteered the job of finding the keynote. And I actually did volunteer because this was a challenging one, because I knew this one was going to go way out of my network. Right? All of you in this room are, in one way or another, sort of in my network, and I can get to you easily. I knew I could not get to any of these people doing this work in these extreme conditions very easily. So I just started cold emailing people. And that kind of worked until I realized that Virginia Giddings and Jane Coyne both went to Cornell. So I activated the Go Big Red. I activated the Cornell Alumni Network to get to Jane. And my introductory email to Jane, she later told me when we met, after she had agreed to do this, she said gave her pause and made her think that actually she was not the right person to give this keynote. And when we sat down to have lunch with her, Virginia and Jane and I had lunch near UCSF, where Jane works now, and I think we managed to convince her that she was the absolutely precisely right person to do this keynote. Because one of the things we like to do at MedtechVision is be very provocative in the way that we talk to you about whatever the theme is for that year, right? And the reason that we do that is because we want to make you kind of go, huh, about something that you've never thought of before, about conditions you've never thought about before, and about something that's completely different than what our day-to-day job is, but is related to what you do day-to-day, and that's hard. And so I'm going to introduce Jane and talk about her background a little bit. You've probably seen it in the program, but I want to make sure that everybody hears it, because this in context is important to listen, as a lens to listen to her, look at what she's going to say, hear what she's going to say. I'm mixing a lot of metaphors. So Jane Coyne is a strategic leader with experience in multiple domains. That is an understatement, by the way. From supply chain management in the tech sector to hospital management in the Congo. Yes, that's the African Congo. After business school at Kellogg, side note, she knows Lisa Earnhardt really well. Small world. She spent 10 years in the Bay Area working for and consulting to companies on supply chain optimization, from inventory management to network design. So far, it's not sounding like this, is it? It gets better. In 2003, she left the corporate world to begin a decade-plus engagement with MSF, Doctors Without Borders. And out of great respect to the French-speaking people in the room, I will not attempt to say the actual name of the organization. We're just going to say Doctors Without Borders, and we'll ask one of you in the wine reception to pronounce it for us. Jane's 6 years of MSF fieldwork culminated in a program manager role based in Paris, responsible for their activities in Sudan, South Sudan, the Central African Republic, Kenya, and Georgia. In addition, she's just completed a 3-year term on the board of directors for the USA part of MSF. Jane recently returned to the Bay Area in 2013 and worked as a director of operations for We Care Solar, helping bring solar energy to health centers with no access to electricity in Africa and Haiti and other critical regions of the world. In fall of 2015, because that's already not enough, right? She began her current role supporting the United Nations Special Envoy on Tuberculosis at the University of California at San Francisco. Jane, we could not be more thrilled to have you to give our close of day keynote, and we'll turn the stage over to you.
I am, in fact, delighted to be here. I did come up with like 5 recommendations for who could do the speech better than me, and they did convince me that I should do the talk. And as I was sitting here and I was listening to the topics of conversation, like the resonance on financing is something that, you know, I've thought about. I've pitched to a VC before, but I can't pitch to you why Africa is a great context and Africa needs more and more adapted health resources. But I think all of you know that someday it's going to be a great market. And what I'm going to describe to you is probably going to convince you that that's about 10 or 15 years away. So I will get started. That was a fantastic introduction. Thank you so much. I will make one other comment before I jump in. In the mentorship discussion, I loved the comment about like know what you're worth and value it. And in the spirit of her boundary definition, I was like, what was my greatest accomplishment? And it was probably my time as head of mission in the Congo, where we had a peak in the violence and incredible teams that continued to operate and provide healthcare. And I walked back into the office in Paris. It was my first time as head of mission, and the president of MSF France is coming out the door, and he looks at me and he says, great job in Congo, you know, like totally scaling up operations, and you didn't get anyone killed. And I was like, well, that is a new benchmark for what good performance is all about. So I have been in some very, you know, it's sort of been in the boundary conditions, and I'm happy to share with you what I know. So I'm not going through my whole bio, but it does kind of go in decades. The sailing phase, my parents were significantly less interested in. The business corporate phase was a lot easier to relate to. I think someone on the panel said they made a big left-hand turn, and I did that in 2003. So my decision to go to work for Doctors Without Borders was, and I will refer to it as MSF, was principally driven by the war in Iraq. So I was pissed off, and I decided that I wanted to spend a year as an American citizen out of the country doing something that I thought was more constructive. I was raised in a conservative family in upstate New York, Catholic schoolgirl. This is the only rebellious thing I've done in my life, and it was good. I learned a lot, and I really enjoyed it. I will come back to tuberculosis in the end, because that is the disease that I care the most about. So first of all, I will not spend a lot of time describing what MSF does. I think many of you are familiar with the organization. The last couple of years, unfortunately, have put MSF sort of in the press, both so 2014-15 for Ebola and 2015 for the violent attacks on our hospitals. But I think it's helpful to do a little bit of a context setting. So it's a emergency medical humanitarian organization, which is like the easiest slice of the pie to cut off, right? So we don't worry about all the questions of sustainability. We don't worry about all of the potential diseases. We're really dealing with the most acute acute care. So the organization was founded in 1971. It's now ginormous, so I refuse to use the word H-U-G-E. I don't know how I got that on the slide, but we're now $1.3 billion a year. Like, we have more than 35,000 staff worldwide. 90% of those staff come from the countries that we're working in. And then there's a chunk that are in headquarters, and then there's a very small minority of staff that are international staff that are traveling to these countries. We work in 70 countries, and the way we have defined need for the 40 plus years of existence came from our charter, and that document outlines the populations that are most vulnerable. And in general, our interpretation of that is people that are suffering from the impact of violence, right? So there's two aspects to that. One is that when conflict starts, the health system erodes, right? So generally, your health staff are amongst the most educated in the country, most of the highest paid. They have mobility. The fighting starts, they leave. Totally human and natural. The populations move en masse, so they displace, and you have additional vulnerability in those populations that no longer have proper shelter, food, access to clean water, living in crowded conditions, et cetera. And so for 40 years, we've essentially developed mechanisms to provide health care to the most vulnerable populations. And the nuts and bolts of that is that about 50% of our work is conflict work, about 30 to 40% of that work is deep medical programs, so HIV, TB, sexual violence, trypanosomiasis, all sorts of exciting things. Some of it is outbreaks. You get another 10% that's outbreaks, so vaccination campaigns for meningitis, different things. And then about 5% of the work that MSF does is natural disasters. And they also tend to take a disproportionate place in the image because they get so much press coverage. So that's what MSF does, direct medical care to the most vulnerable populations. My life with MSF is now stretching on to 13 years, which is somewhat ridiculous. I've never done anything for that long. So I was 5 years in the field, 4 years based in Paris, 3 years as a member of the US board. I started as a logistician. So how do you get from being an engineer to being a person that's negotiating with the Minister of Health or the administrative authorities or your doctors? I started as a logistician. Logistics is everything it takes to run a hospital that's not medical and not administrative. So it's literally electricity, cars, water, radio, computers, supply, all those things. And I was really, really good at that, except I hate electricity. And when the Central African Republic, power project, 3-phase electrical system with all of the wires chewed, I just wanted to shoot myself. And I said, you know what, I'm a good manager. I'm gonna go be a manager. And so I became a project manager. I ironically moved to Congo to improve my French and ended up the head of mission in a war project. So I was the country director or head of mission in Democratic Republic of Congo, particularly in the east of Congo in North Kivu province. And I was the head of mission in Sudan. And then I was program manager or desk manager. Just for a sense of scale, as desk manager, I was responsible for 5 countries, 15 to 18 projects, depending on the time, a budget of about $15 million, and about 1,000 staff. So that is all like background, scale, whatever. I came to talk about my experiences delivering healthcare in Africa. And the first thing is that Africa is not one thing. And we all know this, but I think it's a really useful reminder. And on the right, you see the places I've worked. So I know those countries well. I know the sort of mortality, morbidity patterns. I know how their health systems function. And I will give you little snippets of those things. So what I bring to the table is literally running a vaccination campaign with donkeys in the mountains in the middle of Darfur to running a referral hospital in Rutshuru that is 300 beds with 3 surgical teams and 3 OTs and doing internal fixation and providing other emergency services alongside of that. So I think it's abundantly clear that my experience skews left. So every time I'm in a conversation, and that's not politically left, it's like in the scale of anything functioning left. So for me, the 2 extremes are the Central African Republic, which I have this very warm place in my heart for, and Kenya, were the sort of systems that I know well that go the farthest apart. In 2010, when I was desk manager in Paris, we did an advocacy campaign trying to get more people to invest in health in the Central African Republic because we had mortality rates that were so high that we resent the epidemiology team to collect data because we didn't believe the results. So results in a non-conflict setting in the west of Central African Republic that are higher than Darfur in 2003, how is that possible? And so there's whole swaths of the countryside where we have really no visibility into what the situation is. And so when we were doing this advocacy campaign, my tagline was, the average person in the Central African Republic walks 11 kilometers to get to a health center that has no trained personnel. There's a 50% chance that the drugs that they get are fake, and they spend more than 50% of their monthly salary. Right? Like, that's about as bad as it can get. Right? The reason we're doing this advocacy campaign is we just keep putting more and more and more projects there, because you could put a project everywhere because people were dying at such a rapid rate. So contrast that to Kenya, which is my benchmark for a health system that's functioning. In 2012, when we were trying to close a project, we were considering closing an HIV project, we found that in the immediate vicinity of the project we had in a slum in Matare, there were 12 health centers that provided free access to HIV care. They had very well-trained and very well-qualified staff, generally poorly motivated because of management issues and financial incentives, but they have exceptional capacity. There's a pharmacy and poison board that regulates the quality of drugs in Kenya and supervises and ensures that minimum standards are met. And in Nairobi, you literally can spend $1 on a consultation in a Ministry of Health clinic, or you can go to the Aga Khan Hospital and have a consultation that looks not that different than what you would experience at UCSF or Kaiser here. So it sort of boils down to being stuck in a system where you have no choice in the Central African Republic. You gotta be really sick to walk 11 kilometers to a place with untrained staff and commit 50% of your monthly resources to places where you have choice and you have recourse against the system. So the next set of slides are meant to sort of convey or illustrate what it looks like. You guys all know what primary healthcare is. Infrastructure, like the actual building, is never really the problem, especially for primary healthcare, because it's not, it's by definition not a long-term engagement. On the left, you can see pictures from DR Congo and CAR, Central African Republic. I'm not saying that again. And they're in very different states of repair, but one of the impacts of the way funding works in the developing world is that people like to build buildings. So the buildings are generally there. It's the other stuff that you don't have around, and in fact, the building is somewhat irrelevant to outpatient care. The picture on the right is a malnutrition program that we ran in northern Nigeria in 2005. And that program, we expected 6,000 patients in 12 months, and then we had 12,000 patients in 6 months. And so, like, what do you do with a program that's admitting 800 patients a week when you weren't set up for that scale? And so at the end, sort of by the middle of the program, we could build a new, like, semi-permanent building in 4.5 days. Like, you just have the team and you just run with it. It's easy in Nigeria because you can get the resources for anything. I ran hospitals. The picture on the left and the picture on the right are about as far apart as you can get, right? So on the left, you have an aerial photograph of the hospital compound in Yida, South Sudan. So Yida is right on the border of Sudan. In the summer of 2011, the Sudanese government started bombing the Nuba Mountains, and for the first time, they'd been fighting a war for 20 years, but for the first time, the population of the Nuba Mountains came out of the mountains and settled in this territory in South Sudan. It's in the middle, when I say the middle of nowhere, it's really the middle of nowhere. And so the compound, everything we built in that compound is imported. So you can run a hospital in tents, it's hot and it's hard, but you can do it. So when you look at the compound on the bottom left, you actually have the outpatient wards. In the center, you have the hospital. Kind of in the middle at the top, you have the pharmacy building. The top left is the logistics store. And the circular thing on the right is our bomb shelter. So building a hospital and a bomb shelter together, who thinks that's a good idea? I got there and I was like, either we think we're gonna get bombed and we should move, or we shouldn't build a bomb shelter in the middle of our hospital, but they didn't necessarily agree with me. So, and then the picture on the right is a representation. This is the operating theater in Rutshuru Hospital. So I referred to this hospital before. The hospital, it's a big compound, right? These are permanent structures. They're often sort of connected by the covered walkways. There were 8 wards, men's, women's, surgical, orthopedic, pediatric, ortho, and the ICU in the emergency room. And this is a picture of the operating theater. And the operating theater, it certainly doesn't look like UCSF, but it has continuous good quality power. It has totally Western standard sterilization. We had, ventilation machines. We had a lot of the infrastructure that you could imagine that you use in traditional, or in the global north. I never know how to say that. I always feel like I stutter over it. So infrastructure, I'm a logistician, right? Like this is the nuts and the bolts of what it takes to operate in these places. And as I was looking at the slides today, I realized that I do better in the bottom, right? In each of these categories, roads, electricity, water, sanitation, there's sort of a spectrum of working to not working. And I think actually this might be one of the takeaways for you guys, is that don't be deceived by the infrastructure that exists in the place, right? So if you take the road example, Nigeria has a great road system, lots of tarmac, but you have poor quality vehicles and bad drivers and no regulation, right? The chance of getting in a car accident in Nigeria are a lot worse than the chance of getting in a car accident in Congo, right? Bad roads, mud, you can't go very fast. You might get stuck, but that's not such a bad problem. So if you're looking, it's sort of deceiving with all the infrastructure. With electricity, the only place I've ever worked that had continuous electricity was ironically the capital of CAR, Bangui. And I arrived and I looked at the generator log and I was like, they've only used the generator 30 hours. I was like, these guys are not doing their job writing down when we're using the generator. Turns out that the electricity worked all the time in 2006 in Bangui. That is rarely the case. Nigeria, we had great electricity in Katsina, except that the 220 volts was only 160 volts. And for those that are engineers in the room, your devices aren't going to run very long when you're putting 160 volts into them. It doesn't work. So it's much easier to control the quality of the electricity that you have available by finding an alternate source, either generator or solar if you can do it. And water is near and dear to my heart. My first project in Africa was in Uganda, and I was principally responsible for delivering water and building latrines in a displaced persons camp and a refugee camp. It's just important to remember that the standard, most people are getting their water either from the surface, so taking it out of a pond, a stream, a river, lake, or they're getting it from a well that has a hand pump on it. So there's very few places that have piped running water. Obviously, urban versus rural is a big difference. Sanitation you can talk about in 1,800 different ways, but we're talking about the very basic problem of containing human defecation, right? And most people that do not live in an urban area in Africa do not have any latrine. They just defecate around them, and that works fine as long as you don't have a very infectious disease like cholera or a lot of people crowded in together. I just couldn't resist not using the picture on the left. So I wanted to talk a little bit about this system. So rather than talking about the infrastructure, that is an airplane that MSF hired to fly in medical supplies into Yida camp. And they lost an engine. One of the engines went out on the way there. And I don't know why anyone would make this decision, but they decided to land in Yida knowing that they would just abandon the plane there. So one of the things you see in Africa is that's the airstrip. So that's what you're landing on. And most of the airstrips have planes by the side. So do a lot of verification about the quality of the airline that you're using, because that is not at all consistent. And so what I will say, because I'm a supply chain girl, it's interesting to me, but the reality is that all of the backbone of supply chain, I don't know any health system where that functions very well. If you think about the basics of building a forecast based on either surveillance data or some form of quantification, procuring based on your forecast, receiving and storing the goods in good condition, and then figuring out a way to distribute it. There's a couple of places and a couple of vertical disease-specific programs where that works, but largely it's just 100% improv, right? So somebody calls and says, I need this, and somebody tries to figure out how to get it there. And sometimes that's contained within the ministry, and sometimes that's contained, crosses over between the Ministry of Health and NGOs and other organizations. So surveillance on the right, that is a picture of malaria cases in a health center in Ethiopia. So the red line is the last year's data, and the blue line is the current year's data. That is remarkably effective from an epidemiological perspective. They know what they need to know at the clinic. But Ethiopia has one of the most solid health systems in Africa. And if this is how the data is being captured, somebody's got it in a handwritten journal, and that handwritten journal goes from the health center to the Woreda, and from the Woreda to the region, and from the region to the capital. And that reporting system works. But think about aggregating all that data, then trying to build a forecast, then trying to decide what you're going to purchase. It's a non-responsive system. And then the picture in the center is the headline, right? Human resources are what it takes to deliver healthcare. And when I was based in Paris, I had Georgia and Kenya, Georgia and CAR. Both have about 4.5 million people. In the post-Soviet era, Georgia decided that they had 20,000 doctors, but what they really needed to serve 4.5 million people was 12,000 doctors. So the problem they were trying to solve for is how do you convert doctors into other, right? Either retire them or cross-train them to do something different. CAR had 116 doctors, right? So your target is 12,000, you have 116. How many specialists do you think you have, right? The only orthopedic surgeon and the only anesthesiologist in CAR retired in 2011. They retired because they were in their 70s. Like, they deserve to be able to retire. But if you're the only anesthesiologist in a country, it doesn't mean that he's the only person providing anesthesia. It means that the people that are providing anesthesia are not qualified in any of our standard definitions. It doesn't necessarily mean they're bad at it, but it's a much harder system to walk into and evaluate how people are going to function. So the picture there is it's a diagram, again, on the wall in Ethiopia, teaching people how to observe obstetric cases, right? If you're trying to train people to do what's most important and right and is essential to your job, and you're doing it with written piece of paper, and this is not to be disrespectful to Ethiopia, which, as I've stated, has an incredible health system and is showing tremendous leadership in developing their health system. But they're the good guys, right? It's really hard to deliver quality healthcare when you can't hire enough qualified staff to run a hospital. In a wheel hospital in South Sudan, you could literally correlate mortality and how many unfilled nurse positions that we had in our hospital, right? And so by the time we hit 20 vacancies, we had no control over mortality anymore. You just simply can't run a hospital without enough qualified staff. And so this, for me, is the biggest gap that people, not necessarily med tech people, but maybe, need to be working on. I didn't think I could come here and talk about my experiences without talking about displacement. So I have this t-shirt from when I started, so it's probably dates to 2004, that says 42 million refugees in the world. And then the number went down to 30 million. And now we're at 66 million people that are displaced in the world. What is 66 million? Like, what does that do to future generations? And I just wanted to quickly say that the picture in the middle is August 25th, 2007, when the CNDP attacked Sake. This is what it looks like. This is what you do. You put all of your possessions that are most important to you, which is you think are most essential to your survival, you put them on your back and you walk down the road. And where do you go? You end up in a camp. So this is Yida. So again, this is the hospital compound we looked at earlier. It is, that's how the population lives. Like, there was plenty of place to spread out. But shelter, we give them 16 square meters of plastic sheeting. You build your house and you put plastic sheeting on top. So your house is mud and sticks. I just wanted to emphasize that it's a remarkably dehumanizing experience. It's a moment of extreme vulnerability. And I'm totally convinced that the world can do better than we're doing right now. And some of it will be solutions, adapted solutions that maybe you can bring to the table. So I'm not going to spend a lot of time on this because you are professionals and you know what you're capable of and you know what your challenges are. And I think we're all really sophisticated. I know more about the minutia of constraints in Africa, but we all know that you need to watch out for electricity. You need to watch out for systems that can live in a non-air conditioned environment, in a high dust environment. But I guess my key messages that I wanted to say are prioritize. Like, I don't understand how the world doesn't prioritize based on mortality, right? Like, how can we not be solving the problems that children are dying from and adults are dying from? So I make a plea for prioritization, adaptation. I think there's an element of fighting the system. I think that as companies, it's extremely complicated. Way do you try and get a product registered in 54 countries in Africa? It is not a reasonable process, and I think that there is a lot of advocacy work that can be done by companies that want to work in different places and provide access. I also think there's a lot of other forces that are converging on this and that will end up with some better systems for clinical trials in developing world and for drug registration and drug waivers. And so I guess the final thing I would say is try. So the French use the phrase tout est possible, so everything is possible. And I didn't want to close my somewhat, I guess, different and shocking perspective on things without saying, like, without some sort of optimistic message. So that's it. I am delighted to have shared a bit with you, but I think the far more interesting conversation will be based on your questions. So I'm sure someone will have any questions, but I gave you a few hints for good stories. So the exit stamp question, there are not that many countries in the world that you actually have to have permission to leave. Sudan is one of them. I was the head of mission when MSF France was expelled from the country, and I was detained for 6 weeks, which meant that they had my passport and I did not. And twice I got it back, but it didn't have an exit stamp, so it didn't do me any good. And so the process was complicated to figure out they needed to figure out what they wanted from us because there were a number of NGOs that were expelled at the same time. And once that was done, then there was the process of figuring out how to pay what they wanted us to pay and get that money to our staff. So they asked us to pay 6 months of severance to the staff that they forced us to fire because they kicked us out of the country. And so I am so delighted to have my exit stamp from Sudan. And ironically, I think I wear as a badge of pride the fact that I'm persona non grata in a country. So technically, until Bashir dies, I'm probably not going back to Sudan.
What assumption do you hold going into this experience that was debunked immediately?
Oh, good question. So the question was, what assumption did I have that was debunked by my experiences? It wasn't really immediately. It took me a little bit of time. So it's definitely the notion of black and white versus gray. So nothing. I think I'm sort of coming back to an equilibrium, but when I first left my operational job in Paris, like nothing was black and white anymore, right? There was no good and there was no evil. When you look at the situation in the Congo, there's 26 armed groups signed the peace accord in January of 2008 in an area that's the size of New Jersey. Who is civilian in that area? Everyone is co-opted, right? Maybe the kids under 5. They probably don't do a lot to promote the war. But this notion of there's a good guy and a bad guy, there's a person that is on the virtuous side and a person that's on the negative side. When you spend a lot of time living in conflict areas, none of that seems clear anymore. And I think that is a tremendously powerful lesson that we can learn in a lot of different ways in our life, but I think it makes me more open to hearing people's stories and getting a deeper perspective rather than just looking at the surface of things. And I think it makes me, this is from my first mission, we had a malnutrition program, and Okello was this little guy that I brought when I was driving. I was out on a water project, and I was coming back, and we brought him back in the car because he was really, really sick. And he was malnourished in a family that has cows. I come from a family of dairy farmers. Like, if you have a cow, you can nourish a child. I just didn't understand that. But the economics are such, and the situation is such, that it is easier to get another child than it is to get another cow. And your cow is your family's wealth. It is your legacy. It is your security. It is your safety for your entire family. Can you imagine being the parent that does not give the milk from the cow to the child, but gives it to the calf? Like, I can't pass judgment on that anymore, even though it's shocking to me, because the level of the sort of fundamental humanity of the choices that are being made is at a totally different level. So I guess that would be my answer.
Do NGOs ever share infrastructure? So, for example, does the Gates Foundation partner with MSF to share their shipping or whatever? So do you ever see that, or is it totally equal size?
So the question was, do NGOs ever share infrastructure? And the answer is sort of yes and no. So MSF is really a great organization. I totally believe in it, but it is an outlier, right? Like, 90% of our money is private. We don't have to take money from big governments and institutional donors. We have this logistics infrastructure that's incredible. So we do a lot of that stuff independently, and it's not so much that we don't want to share with other organizations or people. It's just that often there aren't that many people around where we are. So it's not, I mean, that's not true in terms of bringing stuff into the Capitol, but at the project level, that's a little bit true. On the other hand, most organizations are very dependent on bilateral funding and funding that comes out of like the humanitarian pools around emergencies. And the sort of infrastructure is inherently shared because they don't have a big logistics organization. The resources that they're using are going to be, you know, the UN system brings in the food, right? A lot of NGOs do the food distribution, but it's World Food Program that brings the food into the country. So there are some places where the resources are shared, and there's some places where they're not.
Can you talk about tuberculosis?
Oh, I'd love to talk about TB. So this is I think this is the best line. So Ebola was discovered in the 70s. 13,000 people that we know of have died of Ebola, and in that same period, at least 50 million people have died of tuberculosis. It is the #1 infectious disease killer in the world. We're talking a lot about antimicrobial resistance, and you're probably thinking about hospital MRSA, and you're thinking about gonorrhea and other things in the United States. TB is the #1 killer of people from drug-resistant organisms, and it's the disease that represents all of the challenges, right? It's a super old bug that has evolved well to not kill quickly. There's a huge latent pool, so literally 1/3 of the world's population has TB in their body, and they have contained the disease. Their immune system has contained the disease, but if you get HIV or you have something else that suppresses your immune system, you're vulnerable to active disease, so it's everywhere. And we haven't invested in it because everyone thought it was going away, right? The trajectory from 1900 was going down. And so, you know, we have 50-year-old drugs. So rifampicin was 1951, and isoniazid, I think, was 57. So we have super old drugs. We have very poor understanding of the disease because it was going away. We have pretty little attention and investment for reasons I totally don't understand, but it's a marketing problem. I'm sure some of you guys can help me find the key to this. So I care about TB because I ran a drug-resistant TB program in Georgia, and I just totally think it's unacceptable, right? So treating drug-resistant TB, you have 5 drugs that make you sick as a dog, you take them for 24 months, and you have a 50% chance of survival. Like, who would do that? I'd just go to the desert island. I don't want to infect anybody, but who would do that? So for me, it's the big problem out there that nobody's talking about. So I literally wandered around San Francisco, and when people would, you know, I'm networking, and when people would ask me what my dream job is, I would be like, I want to work on TB in the big picture, and they'd be like, good luck, not here. And the miraculous convergence came together. I work for the United Nations Special Envoy on Tuberculosis, who is a UCSF professor, and just an incredible human being. So that's my TB story. And everybody should be working on TB.
Yeah, first of all, I just would like to tell you how amazing you are. and I would love to share your dream. I grew up in Zaire, Republic of Congo. My parents, they grew up over there. My grandparents were over there. And all the pictures that you share, I have seen that.
I know.
But what I heard from my grandparents and my parents is the fact that it was much better in the past.
Yeah.
So it's you said at the beginning that it's gonna change, it's growing. Just 10 years ago, I attended a conference, and some big economists in Europe, they were saying that you have to invest in Africa because things will change within 15 years from now. And I don't see it changing. I mean, what you shared with us, that was the case 20 years ago. There is no difference. It's getting worse. So beyond the I think over there it's the power and the corruption. So what's gonna change? How we will be able to? Because there is another thing that we say in French is impossible n'est pas français. Impossible is not French. So I get the fact that you have to
Where in Congo? Where did you?
I was in Kinshasa, Lubumbashi, Goma, Bujimai, and Bunia.
Oh my God. So everyone in MSF has some affection, like becomes affectionate for one country, and there's sort of a top 5: Afghanistan, Somalia, Congo, Sudan, and Sri Lanka. Sort of those countries hold the heart of people, and I'm a Congo girl. It is the most spectacularly beautiful place I have ever lived. So the picture doesn't work that way. I'll show you the picture in a minute. But I cut it. Zut alors. Okay, so I hear what you're saying, but if you look at the big picture, when you look at the progress on the millennium, does anyone here, oh, I'm gonna forget his name. There's a professor at Stanford who I have a great deal of respect for, whose name I cannot remember, that does, his whole hypothesis is that we're making progress in the countries where governance functions. And when you look inside the Millennium Development Goal data, and when you look at it from a market perspective, we really are making progress. It's just we're not making progress in the Congo, right? So in terms of developing health infrastructure, developing economies that can support business, that is happening in many countries in Africa, but it's certainly not. And one of the things that ironically came out of this math science girl that ended up in the Congo is I spent a lot of time reading American history because I wanted to understand how we became a country, because it is totally magic. Sarah Vowell, does anyone know Sarah Vowell? Yeah. Very funny sort of historian. Like, she describes history as chance. And I think that there's a lot to that. So I totally agree with your statement that without proper governance, without a reduction in corruption, there's places we're never going to make progress. But I think that you can look at other places like Malawi, Zambia, Namibia, South Africa, even Zimbabwe. Like, there are places where I do think that there's a remarkable amount of progress, and I do think it's different than 20 years ago. I do think that there's a very fundamental choice to be made, and it's about leaving lives behind, right? Like, you can say Congo is hopeless, or you can say we have to go now. And different organizations get to make different choices, but somebody has to go save those lives. And it's not just MSF's responsibility, it's everyone's responsibility. So let's talk later. Hi.
Your work is awesome, but it seems very personally taxing. So after 13 years, are there things that you do to stay energized?
Well, I don't work for MSF anymore, right? So I left. So I think my friend from first grade who sent me an email and said, "Enough death and destruction, it is time to move on," probably wrapped it up about as well as you could. Like, it honestly took me 2 years to recover from my job in Paris. Like, it's exhausting. Like, to have any sense of creativity, to have any sense of kind of stability, to have any perspective, it is exhausting. And people definitely deal with the job differently. I would say I'm probably on the end of more affected than others. Like, some people seem to just be able to steam on for forever. I don't have that. A decade was enough for me. I know I'll go back to the field. Like, I'm not done with MSF, but I view it as like, I'm going to get them to give me the TB project in Cambodia. And I'm sure there'll be some big natural disaster and they'll call me and I'll just jump on a plane. But for right now, my plan is to take a step away, and I think that people have to make those choices for themselves.
Is this microphone on?
Yeah.
Okay, you can hear me. So again, somebody else just said it a few minutes ago, and you have done fabulous work. What else besides developing medical devices that can be used under these types of conditions can we do? I mean, absolutely, we should be developing devices that don't require electricity, et cetera, et cetera. But what else can we do besides that?
Well, I think that as corporations, I think that when you look at how you prioritize and value CSR, I think that you can make choices that have. I think it's totally legitimate to make choices to say I'm gonna choose something that affects either my staff or a local context. But you can also make a choice to work on something that supports people that have higher need. This is about the allocative efficiency question. Like the world just does not allocate money to the biggest problems. So use your resources, whether it's money or capacity in your organization, to work on a problem that's underfunded, right? It's not a mystery what people are dying of. It's pretty basic stuff. And there's lots of ways with small and large organizations. Don't try to partner with MSF. It's a nightmare. That you can really make a difference. So I would say that's one answer. My answer to everybody is read the newspaper, man. Like, it's hard to find news on these places, but it matters. It matters to be aware, and it matters to talk about these problems, and it matters to use your energy to work on these problems. So that's my answer.
So can I just add one thing? Somebody told me a while ago, and you may disagree with it, having worked for MSF, that we can all afford to give a little bit. So somebody said to me, $25 a month is not going to do anything to your income, but it will help over there so much. And so that's what we do, $25 a month, online banking, off it goes. And because I think they do an incredible job. And I know you're a little burnt out from it all, but God bless you. So.
I mean, I'm not so burnt out. I mean, I still say we, and I'm working on TB, exactly. I did not want to make an appeal for dollars, but I think yes, you can. So thank you very much. Excellent. Hi.
I'm glad you said that MSF is difficult to work with. So when I was younger and more naive, I tried to work with, because I ran a Roche program for CMV, retinitis, and AIDS patients. But it was impossible to make MSF take our drugs. They were so angry at Pharma that I could never get beyond that conversation. Has that changed?
No. And I wouldn't describe it. I think it's unfortunate when it comes out as anger towards pharma, or is perceived as anger towards pharma. It's always it's positioning with the patients, right? And so there's not a lot of people that can defend pharma pricing right now. So I don't think that that's a disagreement that we would necessarily have in the room. I think the problem is actually much more practical, is that MSF invested in the 80s in its own logistic and pharmacies infrastructure. We import all of our drugs. And in the early days, a lot of it was dependent on donations. And guess what? You're not the most reliable suppliers, right? In general, the donation goes to the bottom of the pile. And we're not going to take expired drugs into a country. Not that we be given expired drugs, but drugs with 6 months towards the expiry date are kind of useless to us. It takes a long time to get things there. And so experience and, frankly, resources mean that we don't have to take donations, and we pride ourselves on independence, and the net of that means that we don't really want your stuff. Right? If you're trying to be able to deliver, right, like, we can pack a 50-ton charter in 24 hours for an emergency. You can't do that when you're waiting for somebody to deliver something. You need it in stock. You need it to be the longest maximum expiry date, and that's how we run. Oh, what is fufu? Fufu, samaki, fufu manioc, samaki, pili pili, and sambe. So it is the best meal in Congo. So it is a glutinous mass, kind of like unbaked bread, that's served with a sauce, and you eat it with your hands, and you put a little hole in it so you can get sauce in when you dip it. You mix in a little fish, and then you have your greens. I think the picture on the left is sambe. Those are the leaves of manioc, which is cassava in English? Cassava in English, yeah. Excellent, we're down to the foo-foo question. Sure.
One more question. What do you think are some ideas for addressing the human resources issue? Are there technologies that can help existing personnel scale, like telemedicine or training for community health workers?
I think that there's a lot that can help, and I think I'm not an expert on this. But if you think the deficit is just so large, and I understand that there are companies in the United States that are trying to figure out, clinical algorithms for helping, nurses, nurse practitioners, doctors make better clinical diagnoses. Like that kind of algorithm for the 5 top diseases in Africa that you could deliver on a text phone. That's maybe a little extreme, but certainly maybe on a smartphone would be great. So that's just one idea. I think that the baseline of it, again, if you go back to South Sudan, 20 years of war, in a wheels state in South Sudan, it's the most illiterate state in the country, 72% illiteracy. So you can't even find somebody that can read and write. How do you get that person to be a functional nurse? The deficit can be very, very large, but the opposite is also true, right? Sudan and Nigeria have insanely great medical doctors. If you ever get sick, have a Sudanese or a Nigerian doctor. Well, if you ever get sick with a tropical disease, they've got the machine that runs where they create great clinicians. And so there are examples on both extremes. So what's the multiplier effect? Like, how do you get from having 1, 2, 3 great medical colleges in a country to having 15 or however many you need? And how do you take and provide less skilled people with a set of tools that allows them to be much more efficient in assessing someone who is critical and referring them on and treating them for basic disease? I think those tools are in the process in some cases, but again, I think it tends to be super vertical, that somebody's working on it for one disease. You need something that's more transversal, I think. Sorry, the light is really starting to bother me. I feel like a chicken.
Or the app. The app can answer that.
Go ahead.
Oh, yes, one more. Okay, here you go. All right, from an engineering perspective, do you think there is more of a need for better infrastructure to support healthcare, like wash, electricity, human resources, or for specific products or devices that can fulfill unmet needs in healthcare?
I think the answer is yes, right? Yes to all of that. I guess what I would say is that there are a lot of people that are already working on pieces of this. And so I think the question that might be more interesting for you is what are the resources to figure out, A, how do you prioritize it, B, how do you know what's going on? And I think I think that's a little bit harder for me to answer because A, I'm not an expert on all subjects, shockingly. And B, I think it's evolving really quickly. So I think the answer to that is yes.
I'll remind you that this is the person that I had to convince was that she would do a good job. Like, she's like, I'm not the right person to audience. I'm like, you are the perfect person for this audience.